I'm Margaret Ogden and I'm a public advisor. My journey was health, public health and social care. So I haven't been actually in the field very long. I think Patrick's been in it for years and years, but mine is sort of more recent in research. So this title of the session is The Role of Public Advisors in Social Care Policy Research. And we have 4 speakers: Patrick Wood, Mike Shepherdson, and John Nelson, and Sarah. Is it Lawton or Loughton, Sarah?
Loughton.
Loughton, okay, thank you for that. So we'll be having the presentations, and then you'll be happy to know that after the questions, there'll be about 10 minutes for discussion and questions at the end, and you'll be happy to know that you get another break. So after that break, it'll be at 3:10, there'll be a 10-minute break, and you'll start up again at 3:20. So I'll try and keep a handle on the time, and I'll also look in the chat. So if you want to add any questions into the chat, we'll try and pick them up. And I think Daniel did say that for anything that we don't manage to answer, it will be followed up later by email. So I'll pass over to you, Patrick. Very good to see you again.
Okay, and you, Margaret, thank you. Okay. So the title of my brief presentation is The Role of a Public Advisor. It's not really the role of a public advisor, it's more some kind of headline reflections based on my personal experience as a public advisor and discussions with people in a similar role or kind of other disabled activists working in other contexts. So the reason, or one of the reasons, that I'm kind of involved as a public advisor with ASCRU PIEG, Public Involvement and Engagement Group, is for the personal benefits. So being involved in that role brings me benefits. It kind of increases my knowledge of research, gives me an increased knowledge of social care issues in general, gives me an opportunity to develop skills and develop networks. And that kind of level of benefit, that knowledge, also influences things I do in other areas. So, for example, I'm the chair of the co-production steering group at SCI, the Social Care Institute for Excellence. I work as an influence and participation coach with Mind. And I also work for a kind of local voluntary sector infrastructure organisation on a project that provides social support for older people. So listening to the 2 presentations earlier was very useful and interesting in that context. So for me, all that kind of activity is one and unified, and everything that I do in all of those areas has an impact in other areas. So we kind of touched upon some of the personal benefits for me. When I was putting the brief presentation together, I contacted other public advisors from ASCRU and asked them what the value of public involvement and in being involved in the group was for them. And these were the responses I received from 2 people. So one person says, I've enjoyed working with the world's top social care researchers as a public advisor over the past years. My contributions and suggestions are always respected. I'm treated like a colleague and receive payment for my work. So that was one person's contribution. And another member of the group said, my concern is always that people who draw on health and social care should get support to live their best life, doing what matters to them, what makes sense to them. I think my contribution is that focus and my knowledge and experience about the realities of accessing services. So both of those comments kind of relate to my experience as well. They resonate with me, and I kind of agree with what the other people are saying, and that gives a kind of indication of a kind of collective view on how being involved might benefit us. From the perspective of researchers and research projects, kind of generally speaking, feedback's indicated the usefulness of my comments and contributions. Sometimes people have indicated how my contributions will or might make a difference. And I've been involved in things like assessing requests for funding as an equal partner or a partner with a valued contribution to make. So that's good. However, I think there's an issue about the importance attached to public involvement by academics. For me, there's a big question on where it sits in their list of priorities. And my impression is that some researchers are fully committed to the idea of public involvement, whereas others really see it as peripheral and take a somewhat tokenistic approach. So a big question for me is what power do public involvement initiatives have to change or influence research themes, the way that research is carried out, and the ways in which evidence from research influences social care, support, and provision, because that's kind of why we tend to become involved. We want to make a meaningful contribution that might result in change. Very rarely, there have been occasions where I've felt somewhat marginalised as the only person with acknowledged lived experience in the room. There's always the possibility that other people there will have lived experience, but that's not why they're there necessarily. And I'm quite used to that feeling now, so I don't find it as uncomfortable as I used to. But I know from past experience that the attitudes of some academics and kind of high-level professionals in general can be intimidating and lead to public involvement representatives feeling bad, which I would think would be something that no one would like to see happening. So to conclude, these are the kind of key questions that arise from me based on my experience, and they were kind of implicit or explicit in what I've just said. It's not my place to dictate what people should think about or be concerned with, but there's some of the issues that I'd like to explore in the discussion following our presentations if time allows. And those key questions are, what is the value of public involvement? That's a very wide question, I know. Perhaps more importantly, what priority is given to public involvement and why? Why is that level of priority given? Or lack of priority? What power do public involvement initiatives possess to bring about change? Indeed, is that what they exist for? Do they exist to bring about change or for some other purpose? And what can be done to ensure that public advisors can contribute in ways that suit them and don't leave them feeling alienated, marginalised, or otherwise upset? So that's my presentation. Then, Margaret, back to you.
Thank you so much, Patrick. You probably could see my head nodding away through your presentation. That was great. If I can now come to Mike, please, for his presentation.
Yeah, sure. Thank you, Margaret. Right, so I'm Mike Shepherdson. I'm working with as a public advisor with the Eshrew team in Leeds, in York. So how did I get into this? I guess, well, my journey, I've been around as a patient, if you like, as a user of the health system for quite some time now, I guess around 50 years on and off. I'm involved with research with Kidney Research UK as an advisor, and with a team in Leeds, the Leeds MIC, which is linked into the NIHR from a funding perspective. And its work is looking at working with smaller providers of mainly in vitro testing opportunities, and bringing, I guess in brief, industry and academia and the NHS generally together. So my interest in that was then in what I'm doing now was sort of peaked with okay, so how do we determine policy? How do we determine funding for policy in a more broader context? So that was how I got involved with the MIC, with the Eshrew team, should I say. Way back in I guess in February this year, the team created and gave some education to us all in terms of how do we determine and evaluate research in terms of policy. I think most of us had a view at various levels and an understanding of how you do that in terms of treatments and blind testing and placebos, this sort of thing, and how you can get quantitative results from that. But it's much more difficult, I think, and challenging in a policy decision, where it's not quite the same. We were finding that, I think, a little bit of a challenge to understand the complexities and the algorithms used to the methodology to determine and evaluate. So the team in York suggested some education for us, which was useful, very useful, and came up with this case study. And the case study that we used was putting GPs into emergency departments across trusts. The theory being that emergency departments obviously face a significant pressure, high volumes of attendances. Many may be people who should be treated within primary care, but choose to go to the emergency department. And trusts were encouraged and then ultimately required to introduce GPs into or alongside the ED care team, certainly in England. The aim being to reduce pressure on those departments, improve patient flow, improve outcomes, reduce waiting times. People would be signposted to the appropriate treatment. So the method, and don't propose to go into this at all, but the process is regression discontinuity is the academic method of evaluating the data that you have to determine, use that to determine the direction of the policy. So the theory was that they knew that for a sample of hospitals, of which there were around 40 trusts with about 4.4 million attendances, we knew, or we thought we knew, or they thought they knew, what hours GPs worked. Obviously that timing was never going to be perfect, but what hours GPs worked and were available within the emergency departments. We knew what time patients arrived. We had a selection of outcome measurements for all the patients, how many patients over the 4-hour target window, how many patients leave and then reattend for whatever reason, therefore maybe not getting the required treatment or being moved through the system in the wrong direction, perhaps. How many patients leave without being treated because potentially the wait times for them, how many patients are unnecessary attendees, so people that should not have been in the emergency department at all. The feeling was all of that data should be broadly available for all trusts. The conclusion of that was that the data was at best quite varied by trust. Having GPs within the emergency department didn't necessarily reduce reattendances. In fact, in some cases and at some times of the day, it was more likely that people would reattend. Unnecessary attendances, there wasn't so much of a positive reduction in those for evening attendances, and I think the outcome would be that quantitatively the introduction of GPs into emergency departments didn't appear to make a significant difference to either the waiting times or reattendances. It was difficult for the team because the trust didn't necessarily know when a GP was on duty, and therefore patients didn't know. So it might be publicised that GPs would be available between a set amount of hours, but maybe the GP just wasn't there, for whatever reason didn't attend. So therefore the patients still went through the traditional route, if you like. Some trusts didn't know which patients were treated by GPs, which patients had been treated by emergency department doctors, and the impact on primary care services and the financial implications of utilising GPs within the hospital environment was not clearly understood. And I think the piece that, the pieces that surprised me the most were that the data that was available was somewhat inconsistent across trusts. It was difficult for me to understand how you could operationally try to run an emergency department without knowing whether you'd got, in this case, a GP in attendance or not, and therefore almost impossible to manage that flow and whether you were making improvements or not. And I think the bottom line was that the policy was implemented ahead of the completion and publication of the data and of the report to the decision makers in total anyway. So I think the outcomes of this for me was this was a fantastic insight into the realities and challenges faced by researchers and developers or developers of potential policy to be published and presented to decision makers. It's certainly in this instance, and a great insight because it understanding the concepts of the economic processes used to evaluate this kind of policy change, potential policy change, made a huge difference, I think, to all of us, all the public advisors involved, to be able to feel more confident in contributing and you know, asking questions that were perhaps, hopefully, a little bit more relevant following this. So my, I guess, summary of it was just a tremendous couple of hours of insight, very open conversation. We were treated, I think, with, you know, as part of that team, we were treated with a lot of respect as we went through that. And really everyone, or the guys presenting this, were very open and open to our trying to answer our questions as best they could. So my view and my kind of conclusion out of all this in summary would be, I would encourage this type of education using an interesting and perhaps in some senses controversial case study was a great tool and a great method to get us up to speed and be able to contribute more to the overall aim of the SRU project team. So again, in summary, my view would be these sessions, kind of sessions, should be held more widely across all the groups. That's pretty much it, Margaret, really.
Yes, thank you, Mike. That's a really comprehensive description of a really important case study. So thank you for that. Come to John, please.
Hi, thanks, Margaret. Hi, everybody. I'm going to talk about a specific project, a project that myself and a number of other experts by experience, one of whom, Sarah Lowton, is also with us today. We were working with Dr. Beth Barham at Newcastle University's Population and Health Sciences Institute. The particular project I want to talk to you about, and I'm not going to talk to you about outcomes of the project. I'm not even going to show you any slides. You're going to have to listen to me, guys. We're going to talk about basically the role of the experts by experience in the project and the value that we bring to these type of research projects. The project in question is exploring older people's support needs for making healthier decisions about alcohol during COVID-19. And the work for this took place over the last year. Beth is actually putting some stuff in the chat area as well, which will signpost you to the written documentation from this project as well, if you wish to look into this further. A little bit of background about myself. I'm a recovering alcoholic and I've been 10 years in recovery now. I'm an NHS recovery ambassador. I worked on the DrinkWise Age Well project, which looked at over 50s, their health and alcohol consumption, among other things. I both volunteered and did some paid work for that project. Paid work was sharing and promoting good practice from the project to frontline alcohol workers. And I know Sarah and other colleagues did similar. I also volunteer with Project 6, which is a Yorkshire-based alcohol support charity, and I work there as a recovery coach, and I'm also a facilitator of a men's health group. And finally, in the post 50 age group things, I sit on the Age UK Age Friendly Cities steering group for Sheffield. The approach to the project, I guess a traditional evidence synthesis where a rapid review was done of research studies exploring the impact of the pandemic on older people's alcohol use and their related support needs. There was also a qualitative side to this, a qualitative study, where people like myself and Sarah came much more into this side of the research project. We analysed data from telephone video interviews, particularly Sarah did this, with people who are over 50. We looked at the anonymised transcripts from the interviews, and we also, Sarah also looked at some web chats from a UK alcohol service, web chats with older people. The contribution from us ranged actually not just to, so I guess, looking at some of the data and the transcripts. We helped to recruit people to take part in the study, people who were interviewed by the researchers. So we recruited friends or people from the social or alcohol support networks that we take part in. I take part, as I just mentioned, in a number of activities, and I was able to funnel people through to take part in the research from that. And we engaged a range of people. They weren't necessarily just people who were identifying as having alcohol issues. There is a wider range of older people. To do this, we met with Beth to advise on the aims and the scope of the study. Right at the beginning, we involved in actually looking at what the aims of the study, what the scope was, and how practical that was, given the nature of the target group that were being studied, and the approach that the researchers taken. How practical was their approach? We brought very much our experience as being recovering alcoholics, people with alcohol issues, and to this, and also our work that many of us have done with other people who are struggling with alcohol issues. So we provided feedback on things like the topic guides and data collections form and checked their fitness for purpose. Again, our expertise our lived experience brings so much to this, and I think is invaluable to researchers to try and get the focus of their research right. As I said, we did provide analysis of the interview transcripts, which was particularly helpful, I might add, because we were able to pick up things that perhaps the researchers wouldn't pick up in the conversations they were having, because they don't have the lived experience that we've got. Our knowledge of the cohort group enabled us to identify patterns that were emerging within the interviews. But one of the things we particularly picked up was the mental health issues. Mental health and addiction is so closely related, but it's not always seen that from people outside of the of those who are working with people with addiction issues. Sarah, do you want to say something a little bit about yourself and also the web chat analysis that you did?
Yeah, hi everyone, I'm Sarah. Yeah, I've had issues with alcohol for the past 40 years. I've only been sober for, say, 15 of those 40 years. And I was lucky enough this time when I was sober to be able to volunteer with Drinkwise Age Well and then get paid work with Beth Barnum, and I was able to help with the web chats. And being a peer support worker, I was given permission to have a look at the web chats, which identified records from the over 50s during the peak of COVID, and we looked at what was going on for these people that led them to have alcohol concerns. The information was transferred to an Excel sheet, which was sent to Beth, which took a long time to do, but she very kindly paid myself for doing it. Some of the things we picked up were that people were very keen to talk to the web chats because they had nobody else to talk to, I think, through COVID. And we found that a lot of people had a form of excuse for their drinking, which a lot of the time it was mental health that was mentioned. We drink because I'm anxious, I'm lonely, all the reasons that were covered under mental health. And yeah, alcohol was a big excuse for that. And also, being someone with lived experience, I feel that I was able to get to know these people. I've got to know them in a deeper way. I've connected with them because I know what it's like to be one of those people suffering day by day with alcohol issues. And that's what I did. And I think it's back to John now.
Yeah, thanks, Sarah. We eventually, once the project had finished, obviously the findings were put out into the public realm. Support and funding had come from the Department for Health and Social Care, and myself and another colleague who can't be with us today, alongside Beth, presented findings to the DHSC. A quick run through key findings. 30% of older people had increased their alcohol consumption during the time of COVID, particularly the 50 to 70-year-olds. But we also found that between 8 and 26% had actually reduced their consumption. Where there was increased consumption, it was very often found to be linked to poor mental health, which reinforces what Sarah's just been saying and also what I touched on before. The impact we had when we did this presentation, I think that really helped Beth and to get across the findings, was that we told our personal stories and recovery journeys, because I think that maximizes the impact and the relevance that we bring to this research because of the journeys that we have all been through. and empathy, and I can't stress that more, our empathy with the people who are actually being studied. And it was really well received by the DHSC policy people. I believe they praised our contribution and continue to do so to this day, which is very satisfying to know. And basically the perspective we bring from the front line is not something I think the policy people usually encounter. And I can't emphasize this more, how crucial it is to use experts by experience to inform and guide studies. It brings a genuine lived experience, a frontline perspective to the research. And in this instance, it wasn't just our recovery journeys, but also our experience of helping and working with others in the alcohol support field, our day-to-day experience of working in that field that brought so much to the project. It's critical to use individuals with current hands-on experience of recovery and supporting and when they're supporting and helping their peers. Sarah, have you got something to add to that at the end from your own perspective?
Yeah, very quickly, I've got a piece of paper in front of me and it's got written on it 2 sides of mum. Okay, it says, there's a wiggly face and it says, when you're drunk, you're embarrassing, you're shameful, you're grumpy, you're drunk, you're confused, and you're not with it. On the other side, it's a happy mum, which is happy, sober, normal, lovable, lovely, and nice. Now that's the side I want to stay. And with my lived experience, I'm hoping that we can make a better future for people like me that have really, really struggled with alcohol. And it's with that lived experience that I have been on the ground in tears in a right state with my alcohol issues. At the moment, I'm on my way up because I know with lived experience, things can only go up. And that's all I've got to say.
That's wonderful.
Sarah.
That's absolutely.
Thanks, Margaret. That's our contribution.
Yes, well, it's been absolutely great. I mean, really honest and open presentations on your research experience and also the impact of lived experience. So well done, everyone. And thank you to Beth as well for putting a couple of papers there in the chat, if anyone wants to open them up and save them. And yeah, thank you very much. We are a bit behind time, so just if there's a couple of quick questions, please. Margaret? Are you able to get off mute, Margaret, there?
Yeah. I'm muted. I'm heavily involved as a PPI rep at the Marsden, where I've been involved for 5 years. So obviously in the health sector, although I've come from a social care background, as people on the call will know. I think the things we struggle with are how you measure impact of what you're doing, how you get researchers to engage with members. Although I have to say, to be fair, it's developed hugely over the time I've been there, not least because we have an employed PPIE lead for the trust who's been able to develop all sorts of things, and we've been my colleagues now heavily involved in the BRC application. They've just had to go back to get another round of funding, and in that document and in funding applications generally, if you don't evidence PPI, you're likely to face difficulties in securing funding. So I think it's actually also a thing of developing the working relationships with people so they get to know you and they start coming to you early on when they're developing proposals, which is certainly what's happened where I am. We're increasingly involved right at the beginning in developing in developing research proposals, which has been good. So I think those principles probably apply into social care as well.
Thank you, Margaret. Yeah, certainly measuring impact is going to be on everybody's agenda, I think. I keep pushing PPI evaluation, and hopefully more organisations will start getting on board with that. We are approaching 3:10. So by all means, put any other questions in the chat, and if you can get back here.